very much for that kind introduction. Hello, everyone. Welcome to today's live class. So our first question, before we go into the questions, I would like to remind you to read each and every question slowly and thoroughly. Make sure you know exactly what is asked, because sometimes the phrasing of the questions is a little different, and that might completely change what they want. So looking at the following anatomical correlations, which one is correct? A, midline cerebellar lesions cause marked horizontal nystagmus. Optic chiasm lesions characteristically produce a bitemporal hemianopia. The physiological blind spot is unaffected by papilledema. Optic tract lesions produce an ipsilateral homonymous hemianopia. And in cortical blindness, pupillary reactions are abnormal. So usually by looking at the choices, 2 or 3 of them you can exclude immediately. So let's look at the correct answer. So the correct answer is optic chiasm lesions produce bitemporal hemianopia. Now this is one of my favorite images, and you've probably seen it before. So when there is a lesion at the optic chiasm as marked with the red circle, you get a typical characteristic bitemporal hemianopia as also circled in red. So explanation, so they're talking about the other things as well. Horizontal nystagmus occurs in unilateral disease of the cerebellar hemisphere with the fast phase directed to the side of the lesion. Lateral cerebellar lesions classically cause pronounced nystagmus, whereas this is rarer and much more subtle with midline lesions. The physiological blind spot is usually enlarged in papilledema as peripapillary photoreceptors are displaced. Optic tract lesions produce a contralateral homonymous hemianopia. And in cortical blindness, remember that the pupillary reflexes, eye movements, and fundoscopy are all normal. So this is an image of the different types of nystagmus and their causes or locations of the lesions. If you're interested, you can later pause the video to just have a closer look. I won't read out everything. So going on to the next question, a 56-year-old asthmatic patient presented to the ophthalmology emergency department with bilateral blurred vision of gradual onset over the last 2 months. On examination, he was found to have bilateral posterior subcapsular cataracts, more in the right eye than the left. And this picture that is given here shows the posterior capsular opacifications if you look in this area, in the slit. So this is on the back surface of the lens. Other medical history, he had galactosemia when still a baby, but this has been treated. He's now on bronchodilator and steroid inhalers to control his asthma. Oral medication includes amiodarone, aspirin, and simvastatin. What is the most likely cause of his cataracts? So simvastatin, galactosemia, amiodarone, inhaled steroids, inhaled bronchodilators. I'm hoping that just one of these is speaking to you, and that is inhaled steroids, because they cause cataracts. Amiodarone can cause vortex keratopathy, which is a change in the cornea. Galactosemia also does cause cataracts, but if it is treated as in this case, the cataract is actually reversible, and this is something to remember. Inhaled bronchodilators and simvastatin are, of course, not known to cause cataracts. So this is just a small picture image showing some common drugs that cause cataracts, easy for you to remember, A, B, C, D, E. So a 65-year-old lady who has a history of chronic anxiety presents with a 3-day history of severe left temporal headache radiating from the left eye to the scalp. She also had discomfort during chewing and eating. Which of the following drugs should be given to this patient while waiting for the results of the diagnostic test? Diclofenac, acyclovir, sumatriptan, carbamazepine, and prednisolone. So the correct answer is prednisolone, because the features described here are classical for GCA or giant cell arteritis. This affects large and medium-sized arteries with a predilection for the external carotid, ciliary, and retinal arteries. Endovascular damage and cytokine-mediated inflammation causes local ischemia. There is considerable overlap with polymyalgia rheumatica, and symptoms of both should be sought. 20% of patients develop loss of vision, which can be prevented with timely recognition and treatment. So this is actually one of the few emergencies that we have in ophthalmology. The symptoms of discomfort during chewing and eating describe classical jaw claudication, and it only occurs in a minority of cases, but does indicate a high risk of ischemic complications. So jaw claudication is actually pathognomonic for GC. The typical presentation is a temporal headache, myalgia, malaise, fever, raised ESR and CRP. One suspected high-dose corticosteroid should be given. If visual symptoms are present, intravenous methylprednisolone can be given, usually in 3 daily doses of 1 gram. Once the symptoms and laboratory abnormalities resolve, the dose of the corticosteroid can be gradually reduced and usually stopped within 2 years. Differential diagnosis trigeminal neuralgia. So this usually presents with paroxysms of pain, which last for 30 seconds to 2 minutes. Carbamazepine is a first-line treatment. However, due to the threat to the patient's sight, it is most appropriate to treat first for giant cell arteritis. Why? Because this is a potentially blinding disease. And as I said, it's one of our few emergencies. So although the pain in trigeminal neuralgia is severe, the patient's not going to die from it. Acyclovir could be used to treat ophthalmic shingles, but you usually expect some skin lesions, which are typical. Diclofenac, is an NSAID, and sumatriptan is used in the treatment of migraines and cluster headaches. So this is just an image of giant cell arteritis, which kind of summarizes everything that we've just discussed. A 17-year-old boy was brought to the emergency department with blurring of vision in one eye. Vision is 6 by 18, that's only 4 lines, and in the left eye it is normal, 6 by 6. So visual fields to confrontation reveal a right temporal visual field defect and partial loss of superior part of the temporal field of the left eye. So where is the most likely position of the lesion responsible for this defect? These are the choices. So the key to looking for the answer is the field defect. The reduced vision got a right temporal visual field defect and partial loss of the superior part of the temporal field of the left eye. So the correct answer is the optic chasm, because we have bitemporal loss. And it's spreading from the optic chasm up the right optic nerve. So occipital lobe lesion causes a congruous homonymous hemianopia, whereas as I just mentioned, an optic tract lesion causes an incongruous homonymous hemianopia. Temporal lobe lesion causes an upper homonymous quadrantanopia. Optic nerve lesions in isolation lead to unilateral visual signs. Again, my favorite photograph. A 30-year-old gentleman visited his ophthalmologist with a 24-hour history of blurred vision in the right eye, mild right frontal headache. He is a type 2 diabetic for 12 years on medical treatment, and examination revealed a central right scotoma. What is the most likely diagnosis? Are we looking at migraine, pituitary tumor, diabetic retinopathy, CRA, or optic neuritis? So the correct answer is optic neuritis. Occlusion of the central retinal artery or one of the branches which supplies the macular region will result in almost immediate diminution or loss of visual acuity in the involved eye and is usually without pain. In a young diabetic, the etiology is usually an embolus of the central retinal artery or a branch. However, in this case, there is pain associated with the visual loss, namely headache. Diabetes is a cause of optic neuritis, which is usually associated with headache. Retinopathy per se will not lead to an acute central scotoma unless there was acute bleeding of new vessels. So this is a differential diagnosis for acute vision loss, and we divide it into painful loss of vision and painless loss of vision. So if painful, we're thinking of acute glaucoma, optic neuritis, and giant cell arteritis. If it's painless, we're thinking central retinal artery occlusion or vein occlusion or a retinal detachment. Which of the following diseases is most likely to be associated with scleritis? Now, this is a pretty easy question. So can I open it up to the forum and ask for an answer, please?
Rheumatoid.
Sorry?
Rheumatoid arthritis.
Well done. Absolutely correct. So obviously, rheumatoid arthritis. And this is something that we've gone over in one of the basic classes, I think. So scleritis is more severe than episcleritis, usually has a subacute onset, and pain is a dominant feature, so much so that the patient can actually be woken at night with this deep, boring pain. It's so bad. Around 50% of patients with scleritis have an underlying disease. And of course, rheumatoid arthritis is the most common of the connective tissue disorders. It's also seen in SLE, reactive arthritis, PAN, ankylosing spondylitis, gout, Churg-Strauss syndrome, syphilis, and granulomatosis with polyangiitis, which of course is the new name for, can anyone tell me? It's Wegener's granulomatosis. Okay, so that's the new name, GAP. So this is a little comparison between episcleritis and scleritis according to the pathophysiology, symptoms, examination findings, and treatment. So a 29-year-old gentleman presents with acute pain and blurring of vision in the left eye. So vision is 6/36 in the affected eye. He has a central scotoma with a right swollen optic disc. So he's affected in the left eye, but he has a right swollen optic disc with normal vision. What is the most likely diagnosis? Retinal vein occlusion, glaucoma, compression of the optic nerve, optic neuritis, or cavernous sinus thrombosis. And the answer is optic neuritis. So this is probably a case in a young male with multiple sclerosis with optic neuritis. So this is an inflammation, degeneration, or demyelination of the optic nerve, and it includes many conditions. So papillitis, where the intraocular part of the optic nerve is affected and the disc is swollen. Retrobulbar neuritis, when the part behind the disc is swollen and it looks normal. And neuroretinitis, when the adjacent temporal retina is also affected. So it's important to note that the disc changes in papilledema can closely resemble those of papillitis. Can I just ask everyone to mute themselves, please? And if the host can kindly do that. But visual acuity is markedly reduced in papillitis and not. Hello, those of you from Farz Academy, can you please mute everyone except me, please? So I'm just going to stop sharing for a moment. Those of you from Farz Academy, can you please mute everyone? Thank you.
Yes, ma'am, already did.
Okay, thank you. Because as it is, my voice is not very good. Okay, so we got here. Right, so this is a summary. Just bear with me 1 second. Right. So this is an algorithm for eye pain, and it depends on whether there is an uptake in the cornea with fluorescein stain or not, and then it divides it, and it's a sort of flow chart. So you can go through this later. I have given the references. A 28-year-old lady is concerned because her right pupil is abnormally large. It was noticed by her boyfriend and they suggested to see the doctor. So no remarkable past medical history apart from an episode of shingles a few months earlier. And she takes the combined OC pill as her only medication. On further questioning, she admits to unprotected sexual intercourse on 3 to 4 occasions over the past 2 to 3 years. The right pupil is clearly larger than the left. It hardly reacts to light at all, but accommodates to near vision. The ophthalmologist noticed that redilatation is very slow. Her blood pressure is normal and general physical exam was unremarkable. So how can the ophthalmologist confirm the diagnosis? These are the choices. Would anyone like to take a guess?
Syphilis serology.
Syphilis serology, yeah.
Well, both of you think that that's interesting. So what do you think she has?
Alvin Robertson.
So she.
Yeah, it's okay. I mean, I'm not going to bite your head off if you're wrong. So please try.
Adie Robinson pupil.
Yeah.
Okay. All right. So if I just go back a second, yeah, because the accommodation reflex is present. Okay, that's why you went for that. Actually, the answer is it's an Adie's tonic pupil, and usually diagnose that by the reaction to weak miotic eye drops. It's characteristically seen in young women and may occur after a zoster episode. So at the beginning, the pupil is large, but over time becomes small and poorly reactive. And it's known as a little old lady, spelled with the capital A for you to remember. So on the slit lamp, you can see small worm-like contractions of the iris, which are in segments, but the diagnostic test is weak pilocarpine eye drops, which induce vigorous pupil contraction on only the affected side and only weak contraction on the unaffected side. In adults, it tends to be benign and is simply observed. However, infants are usually referred because of an association with other familial dystonias. So it's an interesting case. So this is just a little summary of the what, where, and what's the differential diagnosis. Okay, so a 40-year-old lady, emergency department, sudden onset, painful visual loss in one eye, the right eye. Previous mononeuritis affecting right eye and right common peroneal nerves on separate occasions. 6/36 vision in the right eye with loss of color sensitivity. Which of the following would you most likely see on visual evoked potential of the other eye, so the left eye? So reduction in amplitude of the first negative peak, increased amplitude of the positive peak, reduction in amplitude of the positive peak, delayed latency, and reduction in amplitude of the second negative peak.